Hi guys, this is a review video of Physiology, lecture 25 through 27. We have quite a bit of material on this, so we're just going to try to go quickly. That said, I think the good place to start this discussion off is with a reminder that, just like these little stick figures are saying, we live at the bottom of an ocean of gas, which is constantly weighing on us. And this guy at the bottom, you can see, has a higher pressure associated from the atmosphere, so the atmosphere on him, than this guy, who's also experiencing the weight of the atmosphere on him. So it depends on where you are, sea level versus up in the mountains. All right, then for the rest of this, we have a lot of different abbreviations. Honestly, I think the abbreviations are the hardest part, so I just put these here so they can be referred to easily. There's quite a few of them. We have our equations here. This isn't the prettiest particular slide, but it is what it is. All right, so we started off our discussion of the respiratory system with looking at inspiration versus expiration. So in inspiration, aka inhalation, the diaphragm is going to contract, move down, right? And so it's going to expand the thoracic cavity, and we have the external intercostal muscles are going to pull the ribs up and out, so it will also expand the inner thoracic cavity. And then during exhalation, we have the diaphragm is going to relax. That's going to decrease the volume in the thoracic cavity, and the rib cage is going to get smaller. And you have really two types of exhalation. You have this sort of relaxed relaxed passive expiration, where the inspiratory muscles relax. So just saying the diaphragm is going to relax, the external intercostal muscles are relaxed, and the chest wall returns to normal position. So there's passive breathing out, and then you have deep or forced breathing out, right? Just intentionally breathing out. And as you do that, you can feel, right? You can feel your abs flexing. So we have the rectus abdominis, our abs. You have the external obliques right next to them, which are also going to contribute, and then you have the internal intercostal muscles, which are also going to contribute. So in terms of control, though, we have the you have voluntary and involuntary control of breathing, right? And so our lecture is focused on involuntary control, in which case, just like the heart, we have pacemaker cells, and these pacemaker cells are located in the medulla. In particular, they're called the ventral respiratory group in the medulla, so right here. And those pacemaker cells are going to synapse with the intercostal nerves or the vagus nerve overall. All right, and so, excuse me, not the vagus nerve, the phrenic nerve and the intercostal nerves. All right, for voluntary breathing, you have the primary motor control right here, and that bypasses the medulla and synapses directly with the phrenic nerve and the intercostal nerve. All right, so when we talk about the muscles that are involved here, the diaphragm is the phrenic nerve, which synapses C5 through C3, C5. The external intercostal muscles are from those intercostal nerves, the thoracic vertebrae T1 through T12. And then for forced breathing out, the rectus abdominis, our abs, our obliques, and our intercostal muscles. Intercostals, we are intercostal nerves. Rectus abdominis is T6 through T12 for nerves, and then external oblique is T9 through T11. All right, so let's just take a look at that really quickly. All right, so starting with our muscles of breathing out, we have our abs, the rectus abdominis muscles, and you can see the nerve path for this is from the intercostal nerves from TV6 to TV11, from the thoracic nerves. They're intercostal, of course, because we know the ribs are in the thoracic region of the spine. Then we have the external abdominal muscle, oblique, and we have the 9th through 11th intercostal nerves, also helping with breathing out. Then we have up here, the external intercostal muscle is helping with breathing in, and we know that's going to be for it's going to use the intercostal nerves. Then we have the external intercostal muscles, which are going to help with pulling the ribs down and breathe out, decreasing the size of the thoracic cavity. And then deep to that, we have the innermost intercostal muscles. And let's see if we can find the diaphragm. All right, so the diaphragm's there. We know the contraction of the diaphragm expands the thoracic cavity and is going to help with breathing in overall. All right, All right, so now we're going to talk about what's going on with the lung and chest wall during breathing from a physics point of view. And so basically we say that the lung and the chest wall are coupled, meaning we have the lung right here, we have the chest wall right here, and in between them we have an interpleural pressure. And so the basic idea is that if we have this pressure become more and more negative, say now it's negative 10, then 0 is greater than negative 10, right? And so there's going to be a push of the lungs to fill the thoracic cavity overall. All right, and so this difference in pressure we'll talk about a little bit more, but that's the basic premise. And then you also have, going on with the lungs here, you have the pressure of the atmosphere, and right, we're saying 0 here, but that's still that's greater than negative 10, right? And so there's going to be a net push on the, as a result, a net push on the walls of the chest to compress it, right? And so these, there's a couple of air molecules here, but there's a whole lot more out here, right? Same thing here. There's a whole lot more air molecules inside of the lung than inside of this interpleural space. And so the chest wall is going to experience a compressive force, and the lung is going to experience an expansive force when they're coupled together. All right, and so continuing with this thought is, then how can we manipulate this interpleural pressure? And so we know the answer. We use the pressure-volume relationship. You change the volume of the inner thoracic space by contracting the diaphragm, and you'll change the pressure, right? So if this is our lungs normally, I'm going to go ahead and contract the diaphragm. I'm going to make the space bigger in the thoracic cavity. There's more space for the same molecules, so pressure is decreased. Or I could breathe out and allow my diaphragm to relax. The thoracic wall becomes, or the thoracic cage becomes smaller, so the volume decreases, and if volume decreases, then pressure is going to increase. And so we can manipulate the interpleural pressure in this way to cause changes in the movements of the lung, and then changes in the movements of the lung itself. We can then manipulate this guy as well by making the size of the lung bigger or smaller. But the movement of the chest wall, we know, is going to be affected by the muscles, and then that's going to change this interpleural pressure. And if that changes, then the lungs are going to change in volume to continue to fill the thoracic cavity. And if they change in volume, then you have a change in pressure in the lungs as well. And the goal is to get, if you're breathing in, this pressure to be less than this pressure such that air goes in. All right, so basically, what we started to allude to with compression, expansion, is that you can model the lungs and the chest wall as a set of springs that are coupled together. And so the easiest way to talk about this is to initially uncouple them, right? So if you got a puncture in your chest wall, we'd say that the lungs and the chest wall are uncoupled, and the lungs are going to collapse to the lowest volume that they possibly can. So this is the collapsed spring of the lung, its resting position. And then likewise, we said that the atmosphere is compressing the lungs generally, right? And because the atmospheric pressure is greater than the interpleural pressure. So if you were to make the atmospheric pressure and the pressure inside the lungs the same, the thorax is actually going to expand to its resting position, right? So the lungs are normally being pulled outwards, stretched, and the chest is normally being compressed due to this interpleural space pressure. All right, and so if you couple the two together, then we can start to describe volumes that you have during breathing. And so if you were to take the lungs and breathe in as much as possible, your absolute maximum, that's your total lung capacity. And it's worth noting that the thorax, the chest, when it's at its resting position right here, right, you can see this one's bigger than this one when it's uncoupled. It's at 80% of its total lung capacity, the thorax, at its resting position. And then if you were to breathe out, just regular breathing out, you get to functional residual capacity. So this is the volume that's left in your lungs, and just like regular breathe out. And then residual volume is breathing out as much as you can. What's the volume left over overall? All right, so we treat the lungs and the thoracic wall of the chest as a spring. Then we have to define some pressures. We already started to do this, but the pressure inside the lungs we call the alveolar pressure. And so pressure inside the lungs, oftentimes, at rest, this would be the same as atmospheric pressure. But if we want to breathe in, we're going to need to make it lower than atmospheric pressure. Then we have the interpleural pressure, which is going to be less than atmosphere by default. And if we expand the thoracic cage, it's going to go even lower than -4 millimeters of mercury. All right. Then we have the pressure across the wall, right? We said that the difference between this pressure and this pressure is going to drive the lung to expand. So the transpulmonary pressure is this difference in pressure right here. And that's typically going to just say that it's the difference between the lung pressure, the pressure inside the lungs, and the interpleural pressure. And so if you subtract these two, there's going to be less atmosphere. There's going to be a net positive push of the lungs to expand outwards. Then we have the chest wall recoil pressure. We said that if this guy is less than the atmospheric pressure, there's going to be a push inwards. So the difference across the wall, chest wall is our chest recoil pressure, and that's the interpleural pressure, this guy, minus this pressure. All right. Then we have our total recoil pressure of the entire respiratory system, and that's the alveolar pressure, pressure inside the lungs, minus the atmospheric pressure. And so this could be a good use of, like, we want this guy to be less than this guy. So ideally, this is going to be a negative term when we breathe in, and then when we breathe out, it's going to be a positive term for breathing out. All right, we can also calculate it as the sum of the transpulmonary pressure, this guy, plus the chest wall pressure. Okay, there's a decent amount of memorization there. And then in terms of what's actually going on with breathing, as we said, so we're going to describe flow. Typically we use Q, but here we're using F. Flow is caused by change in pressure and limited by resistance. And so R is the airway resistance. The change in pressure is going to be the difference between the pressure in the lungs and the pressure in the atmosphere. And as we said, we want the pressure in the lungs to be less than the pressure in the atmosphere to get air to enter the lungs. And then when the pressure in the lungs is greater than the pressure in the atmosphere, then air is going to exit the lungs. All right. And so here we have different steps of breathing in and breathing out. It's probably easiest just to look here. So we have the diaphragm we know is our principal inhalation muscle. Here's just a simulation of the diagrams. What that's showing, this is inhalation. The thoracic cavity is going to expand. That's going to cause the pleural pressure to become more negative, meaning become less and less than atmospheric pressure. Right? This is relative to atmospheric pressure. As a result of this guy becoming more negative, right, even less than atmospheric pressure, then the pressure inside of the lungs, the pressure across the lung wall is going to increase. Right, you have more of a push for the lungs to expand in the thoracic cavity, and as a result, the pressure inside of the lungs is going to decrease. And then you're going to, right, you have the lung volume increasing, air is going to flow into the lungs as a result. As air flows into the lungs, then the pressure inside the lungs is going to start to increase. Then you have exhalation, where we know the diaphragm is just going to relax. If that's relaxing, then the thoracic wall is going to get smaller. The lung volume then itself will get smaller. The pleural pressure is going to increase because the size of the thoracic cavity has decreased. So if the volume of the thoracic cavity is decreased, and the pressure in the interpleural space is going to increase, this causes the lungs to get smaller. And if the lungs get smaller, then the pressure inside the lungs is going to increase, and that's going to force air out of the lungs. All right, and then we'll see that the pressure inside the lungs will neutralize or become approximately equal to atmospheric pressure at the end of the cycle. All right, and then you start over. So that's what this says. So I don't want to have to read it out loud, but you can take a look at that. Here we have a bunch of review questions. I encourage you to look at the document to look at the answers. We'll stop there temporarily. All right, so now that we've looked at the coupling of the chest and the lung, the next thing to discuss is the compliance of the lung. So basically the idea is that breathing is dependent on the pulmonary system's compliance, aka the ability to change in volume depending on the pressure. And so compliance is defined as change in volume per unit pressure, C equals delta V over delta P. And the determinants of lung compliance are going to be elasticity, whether or not you have surfactant, gravity changes pressure, air pressure based on how much air molecules you have above you, disease states, obstructive versus restrictive diseases, and then dynamic compliances having to do with airflow, whether or not your bronchial or your pulmonary vessels are constricted or relaxed overall. All right, and then for chest wall compliance, elasticity of the chest wall, how intact your respiratory muscles are, whether or not you have extra weight on, obesity, and then if your muscles are properly innervated. All right, so these are the factors that affect compliance. We have this curve of volume versus pressure just to illustrate the idea that compliance is equal to change in volume over pressure. So for a volume versus pressure curve for breathing in versus breathing out, compliance is equal to the slope. And you can see that during breathing in, you have the pressure inside the lungs less than atmospheric pressure right here. Right, that's what's going on here. And by decreasing the pressure inside the lungs, you're going to have the volume and the lungs go up in the sense that you'll have air coming in. And then in expiration, you decrease the volume of the thoracic cage to increase the pressure on the lungs, and you'll have air go out. All All right, and then just worth noting quickly, the difference in the inhalation and exhalation curves is called hysteresis, and you want to see that overall. All right, so we said surfactant and surface tension is an important part of lung compliance. We're all familiar with surface tension, so I just want to quickly point out a couple things. Surface tension is going to decrease alveolar volume due to intermolecular attraction. So we have the positive and negative ends of the water molecule are going to attract each other. And so, if you're on top of a surface, you'll get a shape that looks like this. And the net force will be downwards, but you also have water molecules pushing back upwards, so you get this nice film. And then if you were to extend that to, like a test tube, we're familiar with the meniscus, so we have some attraction to the walls of the container, and then the molecules are attracted to each other. And so extend that to, now instead of a test tube, you have a alveoli, right? And so the water molecules are attracted to each other. And unfortunately, the net result is you're going to decrease the volume inside of the alveoli. Whereas if you add surfactant, the idea with surfactant is you're going to add these molecules in between our water molecules, and so these surfactant molecules are going to increase the distance between the positives and negatives of the water molecules, and therefore reduce the surface tension and maintain like a minimum size for our alveoli. All right, and so the idea here is like without surfactant, this is one of the things that can happen. It's unfortunate. We can model the pressure inside of an alveoli with this equation, Lone-Laplace law, and basically, if we have a small alveoli, the radius is going to be really small, and so the pressure here is going to be a little bit greater than the pressure over here, and so you'll have from high pressure to low pressure net airflow. And it's going to exacerbate the problems that we have here, where the molecules of water are going to be attracted to each other, and so you get like a net result of collapse of an alveoli. So it's quite bad. All right, and so surfactant can keep this from happening by making sure that the intermolecular forces between the water molecules are not like having this problem occur. All right, so what happens when you breathe though? If you breathe out, the surfactant molecules are going to come closer together, and you also have something called adsorption, which occurs. I had to look this up, but absorption with a B is something like eating a cupcake, right? It goes into your body, you absorb it. Adsorption is like wearing a cupcake on your face, right? And so here we have absorption. If you breathe out, then these do get smaller. To a certain extent, and then once it reaches kind of its maximal smallness, then you have some of the surfactant molecules will go onto the surface in a process we call absorption. All right, and then in inspiration, the molecules spread out, like we have over here. Okay, so that's about it for that. Gravity and its effects on lung compliance is pretty straightforward. The idea is that based on where you are, we have higher or lower pressure, and this applies to the lungs too. So you're going to have right here at the top of the lungs, less pressure because each of these molecules of air, even if you're inside the lungs and not exposed to atmosphere, right, they all have mass, right? And so down here they're all going to kind of collect because they're being pulled down by the force of gravity. So you have more interpleural pressure here, less interpleural pressure here, and so just generally the net result, whereas the pressure in here, inside the lungs, is going to basically because you have a greater pressure, or less pressure up here, there's going to be more sort of transpleural pressure up here as a result, and you have greater distension of the alveoli at the top, and down here you're going to have more compression. So the idea is that at the top of the lungs, because the transpleural pressure is greater, meaning the pressure in the interpleural spaces is less, you're going to have reduced compliance at the top of the lung because the alveoli are already kind of spread out. And then at the bottom of the lung, you're going to have increased compliance because they're capable of becoming bigger. Their default state is a little bit more contracted than natural than at the top due to the force effect of gravity. All right, disease states can also affect lung compliance, and so we'll be looking at decreased compliance. You have restrictive respiratory diseases where it's hard to inflate the lung. Right, so please hear this in your brain. Restrictive respiratory disease is hard to inflate the lung, and then obstructive lung disease. It's when you have less recoil, so you have destruction of elastin and collagen, so you have increased compliance overall, and this is when air gets trapped in your lungs. Okay, so we'll take more look at that in just a second, but before we go on, overall total lung compliance, how would you calculate that? Well, you're just going to do the volume you have at the end of breathing out versus the volume you have at the beginning of breathing out, and you just plug in your values into this equation, so not too bad. It gives us average lung compliance is about 0.2 liters per centimeter of H2O. All right, we'll take a quick break there. All right, so we're getting a bit closer done. We have the next idea is that the chest wall and the lung compliance are in fact coupled, and so really we're given this diagram in lecture. I think this diagram makes things a little bit more confusing, but the basic idea is that compliance delta V over delta P, changing volume caused by changing pressure, is really dependent on the fact that the chest wall and the lungs are coupled, and so basically this whole diagram is really just a reiteration of the spring model, and so at different points in this diagram, starting with A, the chest wall determines compliance limits at low lung volumes. So if we're dealing with this point right here, you get to such a volume, or a low volume, that the chest wall is going to say like, no, I'm not going to get any smaller, right? And so the chest wall is not going to get any smaller, and so the lungs could collapse more past that, but they won't, because the chest wall is going to say, I'm not going to get any smaller. The interpleural pressure is going to keep the lungs from getting smaller, right? And so the compliance, the change in volume over change in pressure of the lungs is going to be coupled to what the chest wall is doing. All right, and so that's really what this entire slide is saying. All of these 3 points are a reiteration of what we've already discussed. So that said, at the opposite end, right? So this is when we have very low volumes right here. If we're at high volumes, E and F, then the lung is going to determine the compliance, right? And so the idea is that if you have the chest wall by itself, it rests at about 80% of total lung capacity, and so basically what this is saying is that the lungs can inflate past 80% of total lung capacity, right, by definition, and so the lungs will go until they get to 100% total lung capacity, and at which point then they won't go any further and compliance is limited, right? But the lung itself is going to determine compliance at high volumes because it will go past 80% of total lung capacity, and then you get to 100%. You're completely limited by right up here the combination of the lungs and the chest wall. There's like neither of us are going to get any bigger, so for any change in pressure, we're not going to have additional change in volume. All right, so that's basically what the slide is saying it in a weird way. Okay, then we have dynamic lung compliance. If you're talking about the idea that we have more going on in the human body and in breathing than just like the lungs and the chest wall, what about airway resistance? So the flow of air itself, whether or not it's easy for air to get in or not, is going to have a factor in the change in volume of the lungs and chest, right? Same with tissue, like is the lung able to collapse or expand easily? And then in lecture we had inertia mentioned, but it wasn't really expanded on. Just a reminder, inertia is objects in motion will stay in motion unless acted upon by an outside force. So presumably if you're exhaling, you're going to continue exhaling until you have the chest walls like now. You're not going to get any smaller. All right, so then airway resistance, we're very familiar with. Flow, we've used Q, F, and V now for flow, is caused by pressure, limited by resistance. Resistance is dependent on the lung itself, right? So the tube that the air is going through, the radius, the viscosity would have to do with like the mucus production and the air itself. So I suppose you could have humid versus not humid air. The length of the tube. Airflow pattern, if you have more turbulent air, that's more resistance, right? The air molecules are going to be all bouncing around, versus laminar flow, it's easier for the air to move overall. And then you have these transitional flow points with some turbulent flow at points of bifurcation. With airway resistance, we know it's dependent on radius overall, so branching comes into play. We have 16 generations in the conduction zone and 7 generations of branching in the respiratory zone. And so the idea is that for the conducting zone, you're going to have the least cross-sectional area at the medium-sized bronchi, and so you'll have the most resistance there. And then just like with capillaries, when you get to the smaller vessels, the terminal bronchioles, and then the respiratory zone with the alveoli, you actually have so much cross-sectional area as a total, right? There's just so many of these alveoli, so many of these terminal bronchioles, that the resistance overall is less, despite the individual tube being quite small in radius. All right, so airflow patterns we're familiar with. You want to see if it's turbulent, you use Reynolds number. Just throw in the values: density times velocity of the fluid, times diameter of the vessel divided by viscosity, and then it's turbulent if you're over 2,000. Sometimes we see 2,200 as the number, but over 2,000, you can say it's turbulent or likely turbulent. All right, so then we also have this idea of dynamic compression. And so before we go into this discussion, basically the premise here is that the flow of air itself will change the pressure in the lungs. And in certain circumstances, such as very low lung volumes, you can have like partial collapse of vessels, or at the very least, you can have some additional like compression on the airways. And so the idea is that, right, here we have inhalation, normal, exhalation, and then pucker mouth, which we'll talk about in a second. But just take a look at exhalation. The interpleural pressure is plus 10, okay? The pressure inside the lungs, the alveolar pressure, is 15. And then we know that due to the effects of gravity, this pressure right here is going to change, right? And so we have plus 12, plus 8, plus 4, okay? And so due to the effect of gravity, we have changes in pressure, right? That should also be occurring with this guy as well. So, it has an effect, but what's really going on with the dynamic airway compression is this idea that as air flows, you get this Bernoulli effect, which is, right, so imagine if you have, you use a shower, presumably, no airflow, or very little, then when you turn on your shower, you have flow of liquid, and the shower curtain bends inward. Why? Because the pressure adjacent to the flow of water has decreased, right? And so the air here is kind of like the walls of our vessels in the lungs, and the flow of water here is like the airflow in the lungs, all right? And so the idea is that an increase in velocity will decrease the pressure on the vessels. A decrease in pressure on the vessels, right, we go 12, 8, 4, means the pressure inside the vessels will become less. Interpleural pressure, it's not the pressure, the air in the interpleural space is not moving itself, right? So that's relatively constant if we talk about the Bernoulli effect. And so you can have, as a result, as you have this flow of air through the lungs, and then the idea is, right, we also know that the speed of air also depends on the size of the tube, right? We said that, go back to our hose model, right? If you cover this up with your finger, mostly up your finger, the water sprays out really fast, whereas if you don't cover the hose, it goes slower, right? For the same water flow amount, right? The net flow of water. And so, if you get further and further up with less cross-sectional area, then the velocity increases. If velocity increases, you get this effect more. And so you can have compression of the upper airway tubes. And so this is dynamic compression. As you have airflow in, you're going to have compression of the vessels. And then in bad cases, it can cause collapse. But the result is that compliance is decreased as a result of the moving air itself, right? So in the case of someone with COPD, they try to counteract this by pursing their lips. And when they purse their lips, they're making the highest up point the point of greatest resistance. And so the idea is that, right, we go back to this pressure resistance curve. This is our lungs, and we pinch right here, then we're going to keep the pressure below the pinching point relatively high because it's harder for the air to escape. Okay, and so the idea is, if you make this the highest resistance point, then you can increase the pressure overall, despite the fact you have drop off due to the Bernoulli effect, increased velocity due to decreased cross-sectional area, and increased velocity means decreased pressure inside the vessel, which means you could have collapse potentially. All right, yikes, that was quite the concept. So we have basically, additionally, for dynamic lung resistance, we're familiar with vasoconstriction, so same principle applies. Instead, it's bronchoconstriction, bronchodilation. Parasympathetic nervous system, rest and digest, is going to do bronchoconstriction. Sympathetic nervous system is going to do bronchodilation. Sympathetic nervous system, direct innervation doesn't do too much, but circulating catecholamines will do a decent amount of bronchodilation on alpha and beta 2 receptors. Parasympathetic nervous system, vagus nerve, acetylcholine on muscarinic receptors, and then non-adrenergic receptors. We have a vasoactive intestinal peptide, VIP, and then our friend nitric oxide will cause bronchodilation. And then inflammatory mediators, histamine and serotonin, released by mast cells in response to antibodies, will cause inflammation and bronchoconstriction overall. All right, so here's the review questions. Take a look at them. They'll be in the document shared with the video. All right, take a quick pause there. All right, so we finally reached our last set of topics. This is the volume of air inside the lungs. So we have the concept of dynamic lung volumes. In particular, we have tidal volume, which is the volume of air that is inhaled and exhaled with each breath in and out. this is going to be equal to the dead space volume plus the alveolar volume. And we're like, what are those two things? Alveolar volume is the volume that goes into the alveoli with each breath, and then dead space volume is the volume that's in structures that don't contribute to gas exchange. And so that can take a couple of forms. Canonical dead space, which are air inside of the structures that are not contributing, conduction zone structures in particular, and then alveolar dead space, alveoli that are not perfused or poorly perfused, leading to wasted ventilation. And then physiological dead space is the sum of the anatomical and alveolar dead space. So again, it's just like the sum of the air inside of lungs that's not being used in gas exchange. All right, for whatever reason. Okay, so then if we take a quick look at the breathing cycle, this is just my own version of the diagram given in the notes. First, if we have at the end of breathing in, you have the air inside of the lungs, and then you have about 150 milliliters of dead space air. All right, then you breathe out. The dead space air, right, the air associated with like no gas exchange is breathed out as part of this like roughly 500 milliliters of air that goes in and out overall each time you breathe, the tidal volume. And so you breathe out, 150 dead space air goes out, 350 alveolar air goes out, and the former air that was occupying the sort of dead space structural region not involved in gas exchange has been replaced by air from the lungs. So you have 220 inside of the respiratory region and then 150 inside the conducting region. All right, so continuing to breathe out, you get to this stage. Then breathing in, you're going to take in this stale air that came from inside the lungs to occupy the dead space region. That, as you have air coming in, is going to be pushed further into the alveolar space. And then you have, of this 500 milliliters approximately that comes in, 350 of that is going to go to the alveoli, and then 150 will stay as dead space air. All right, so the basic idea is that when we breathe in and out, we have the tidal volume. It's the dead space air plus the alveolar volume that's changing, this 500 milliliters overall, so it's not too much. And then if you wanted to calculate, how much air somebody breathes out over the course of 1 minute, you calculate the ventilation volume, and that's just how many breaths you take in a minute times how much air comes out every time you breathe. Okay, and again, tidal volume is the sum of this dead space air plus the alveolar air that came out of the respiratory portion of the lungs. All right, then we have the idea of static lung volume with the spirograph. This is just kind of, you got to memorize this, there's nothing fancy here, and know the different parts of the graph. So I don't want to spend too much time going over this, but we have the inspiratory reserve volume, that's the amount of air that can be forcibly inhaled after normal tidal volume inspiration. All right, and that's right here. Then we have tidal volume, which we're familiar with, and you can see that, right, it's the volume that goes in and out with normal breath. Then we have expiratory reserve volume, the amount of air that can be forcibly exhaled beyond tidal exhalation, right? So that's this value right here. So you can forcibly breathe out additional value. All right, then we get to the concept of forced vital capacity. So this is the max amount of air you can forcibly exhale from your lungs, right? You can see that right here. All right, okay. Then vital capacity, the maximum amount of air a person can inhale after maximum exhalation. Residual volume, the amount of air that remains in a person's lungs after fully exhaling. Then we have total lung capacity, which we're familiar with. Inspiratory capacity right here, the maximum amount of air that can be inspired following a quiet and normal expiration. And then functional residual capacity, the volume remaining in lungs after a normal passive acceleration. And then these two are really quite important, or these three right here. So forced vital capacity, the maximum amount of air you can forcibly exhale from your lungs after maximal inhalation. So you breathe in as much as you can, and then you breathe out as much as you can, and the amount that you breathe out is this guy right here. And the forced vital capacity over 1 second is the FEV1, and these two are very important in diagnosing pulmonary diseases. So you can take a ratio of these two and it'll allow you to determine if you're dealing with obstructive disorders or restrictive disorders. All right, which brings us to lung disease. So the idea is that you can use static lung volumes to determine if there's a lung disease. In particular, our important determinants are forced vital capacity, aka the amount of air you can forcibly exhale from your lungs after maximal inhalation, and then FEV1, the volume of air expired in the first second of a forced vital capacity maneuver. And basically what we see is that with obstructive airway diseases, which are air gets trapped in the lungs and you have loss of lung capacity, or lysticity, right? This is the ones we said had greater compliance. Air gets trapped. So with obstructive airway diseases, you're going to see a decrease in both of these values. And then with restrictive airway diseases, it's hard for air to inflate well, or it's hard for the lung to inflate. And so we have a variety of different diseases. But specifically, I think what was given to us as prime example, fibrosis, it's hard to inflate the lung, restrictive airway disease. And so you see with both of these, we have a decrease in forced vital capacity and FEV1. And so how do you tell the difference? Well, there's a couple of different ways. The first is by looking at the ratio of FEV1 over forced vital capacity. And for obstructive diseases, you're going to have a decrease in this ratio, whereas for restrictive diseases, it's just about normal, right? You can exhale relatively fine in restrictive diseases, but you just can't inhale relatively fine, all right? Or you can exhale at a reasonable, like the ratio is staying the same. All right, and that brings us to a couple of other factors. So total lung capacity, residual lung volume, and then functional residual capacity for obstructive diseases are going to actually be elevated compared to normal. And why is that? Because you have air gets trapped in the lungs in obstructive airway diseases, and for restrictive airway diseases where it's harder to inflate the lung well, these values are going to be decreased. Okay, then we have our review questions. You can take a look at those, but we are done with this review. So good job, guys. That was probably our hardest one yet.